It's my privilege to introduce Mary Fareed, who is a clinical instructor at the Department of Medicine and Division of Digestive Diseases. Mary is one of our superb clinicians in the Santa Monica practice, and she's going to function as moderator for the next session. Mary.
Okay, so it is my pleasure to introduce our first speaker for this session, Dr. Daniel Uslan. Dr. Uslan is the director of the Antimicrobial Stewardship Program for the UCLA Health System. He is the associate director of clinical epidemiology and infection prevention and assistant clinical professor in the Division of Infectious Diseases. His clinical interests include bloodstream infections, surgical infections, and endocarditis. His research interests include medical device infections, antibiotic utilization, and optimization. He will be giving us a unique infectious disease perspective on how to manage H. pylori infection, a commonly encountered problem in our GI practices. Welcome, Dr. Uslan.
Good morning. Thank you, Dr. Fareed and Dr. Roth, for the introduction, and thank you all for being here on a beautiful Sunday. It's going to be 80 degrees, so I hope everyone has a swimming pool in their future. All right, let's see if I can get this working. Okay, there we go. All right. So I'm an infectious diseases specialist, and I think I have a little bit of a unique take on this compared to most gastroenterologists, and I'll give you a little bit of a perspective on exactly why this is an interesting issue for the ID physician. When these patients come to see me in ID clinic, it's typically because they've failed multiple regimens. So the standard triple therapy PrevPAC approach obviously has been tried multiple times and doesn't work. So I want to walk you through a little bit about how I tend to approach resistant H. pylori infections. So I'm going to start first with talking about where we've come from, and I think everyone in this room is well aware of the very fascinating and unique history of H. pylori. So I had a couple of quotes here from the Pharmacologic Basis of Therapeutics, which is from 1955, second edition. And treatment of peptic ulcers back in that day was placed emphasis on diet and rest. The patient is fed a bland diet, and small meals are given at frequent intervals. Milk, cream, and protein hydrolysates are often prescribed between meals. Rest is essential. Some gastroenterologists routinely recommend hospitalization for several weeks. It's pretty amazing how much our understanding of this disease has changed in that time period. Oh, mild sedatives are frequently beneficial. I suppose if you were going to put me in the hospital for several weeks, I would need some mild sedatives. So you all know this, and I just include this to make sure we're all on the same page about triple therapy. So, of course, classically in the late 80s and 90s, this was the standard approach to H. pylori, and still really it is. 90% cure rates, and the reason I'm up here giving a talk, I think everyone in this room is also aware that the cure rates have been dropping, 75 to 80% cure rates with triple therapy, which is mainly felt to be due to resistance with clarithromycin. Still, triple therapy remains the first line. The classic, of course, is the OAC, PPI, plus amoxicillin plus clarithromycin. That's the classic PrevPAC. And classically, if the patient is penicillin allergic, truly allergic, not just, I had a rash when I was 3 years old, you can change the amoxicillin to metronidazole. The problem now is that since the 90s, we have now developed an alphabet soup of regimens for H. pylori. We've got LAC and LOAD and BMT and the ACG, NICE, LCM, and as an ID specialist, all these acronyms are just very confusing to me. I like something nice and straightforward. So part of the issue with this is that this is the most common infectious disease in the world. 50% of the world's population has this, which means there's been an incredible amount of research and publication in this field. The problem with that is that you've got publications coming out of China and Switzerland and the United States. How do you interpret those? Are they applicable to different geographic regimens? And certainly, how do you synthesize all of these acronyms into an actual pragmatic approach to taking care of these patients? So stepping back a second, when I think about a patient who we're treating for H. pylori, there's really three possible outcomes for that patient's course. Of course, we can eradicate them, which is optimal. You could treat them, but their H. pylori remains positive. So you've done a breath test 4 to 6 weeks later, and they're still positive. So that's a failure of an initial treatment. And we'll talk about why that could be in a second. Another possible outcome is that you treat the patient, follow-up tests are initially negative, so you've eradicated them, but then they become positive later. So that's recurrence. You can get a recurrence, two possible mechanisms. Either you can get recrudescence, meaning that it wasn't completely eradicated, just mostly eradicated, enough to make the tests negative, but now they come back and have a recurrence. Or they can actually get reinfected, which is not uncommon, especially in developing countries, where somebody may be completely treated and then go ahead and get a relapse, not because they failed the initial treatment regimen, but because they get reinfected. So the factors that impact a patient's likelihood of eradication, of course, bacterial resistance, which is why I'm up here giving this talk, and I put resistance in quotes, and we'll talk about that in a second. Compliance to therapy, critically important. You all are well aware of this. Bacterial load, certainly the higher the load in the gut, the higher the likelihood of failure. I won't go into too much details about the pathophysiology, but I'm sure a lot of you are aware of CAG-A, cytotoxin-associated gene A, which when present is associated with poor treatment outcomes, smoking status, and then certain gastroduodenal pathology. But the single biggest predictor of treatment failure by far is noncompliance. And often when you start to press these patients, you'll find that that's fairly common, and especially when we're asking these patients to take 12 pills a day or to dose them 4 times a day. And a lot of you are aware there's a lot of side effects, including metallic taste and nausea and other problems with these antibiotics. So Dr. Roth had actually sent me this very interesting article, which I wasn't aware of in the GI literature. This was Clinical Gastroenterology and Hepatology. Rational Helicobacter pylori therapy, evidence-based medicine rather than medicine-based evidence. So I thought that was a very compelling title, and I found this paragraph very interesting. It said, similar to other infectious diseases, treatment results are best when reliably excellent regimens are used to treat patients with organisms susceptible to the antimicrobials chosen. I agree 100%. Pre-treatment susceptibility testing, either by culture of the organism or indirectly by molecular testing, etc., allows one to select a regimen tailored by antimicrobial susceptibility. Well, that sounded really interesting. The problem is that this actually isn't available in routine clinical practice, and actually, from a microbiology standpoint, doesn't really make a lot of sense. So let's talk about this for a second. First of all, it's extremely difficult to grow H. pylori in culture. In fact, growth of H. pylori, let alone susceptibility testing, is extremely rare to find in clinical laboratories in the United States. And only a very, very few reference laboratories, like Mayo Medical Labs, for example, would even offer this as an option. Certainly UCLA doesn't, and our director of microbiology said, I don't know of any other academic center that doesn't have a major referral practice that does this at all. It's extremely difficult, it's time-consuming, and the other interesting thing is that interpretation of susceptibility testing is extremely subject to opinion. So what I mean by that, a lot of you have heard of the CLSI, perhaps. That's the Clinical Laboratory Standards Institute. That's the organization that sets breakpoints for microorganisms. So when you get your E. coli and there's Cipro 1S, that's the organization that says 1 means susceptible. So CLSI has only set a breakpoint for clarithromycin for H. pylori. So they will tell you for a certain MIC value, that means it's susceptible or resistant. All the other antibiotics, including metronidazole, there are no breakpoints because CLSI basically has said that we cannot interpret how to do susceptibility testing in this organism. Metronidazole in particular, when you read the literature, often it will say metronidazole resistance was 26% and et cetera, but it's actually highly variable, incredibly inconsistent, and changes dramatically depending on what methodology you use. A lot of the GI literature doesn't specify that, but from a microbiology standpoint, different test methodologies can yield different results. Another challenge, especially with metronidazole, is that the pathology of what's going on an enzymatic level to lead to resistance are not well understood. It's thought to be multiple processes simultaneously, and what that actually leads to phenotypically is a very large spread in MIC values in the same organism population. So even if you grow it up in culture, you've got a large spread of potential values, and you may have resistant and susceptible isolates in the same patient. One of the test methodologies you'll commonly see done in a lot of the published studies is what's called an E-test. That's where you drop a little strip with different concentrations of antibiotics on the Petri dish and it diffuses out into the media. But using that test over the reference standard, which is called broth microdilution, actually will increase your resistance by 40% because the test isn't as accurate. So a lot of problems fraught with susceptibility testing for H. pylori. There's also a lot of caveats with the interpretation of this. First is minimal data showing that MICs above a certain point are associated with a poor outcome. So even if CLSI said that 1 equals S and 2 equals resistant, there's not good data showing that patients with higher values actually do poorer. And it's not really clear, like I said, what the causes of the MIC elevations are. So you shouldn't really be saying it's resistant. From again, a microbiology purist standpoint, it's better to perhaps say that this isolate has a high MIC compared to others. But the caveat, of course, is that means if it's only tested by the exact same method, which a lot of variability there. So interesting take on it from the micro standpoint. The other challenge with resistance, at least in the United States, is that we don't do routine surveillance in this country. To my knowledge, there's only been 2 publications that have actually looked at resistance. One was from the CDC. That was the HARP study. That was 98 to 2002, so the data is more than a decade old. That was the H. pylori antimicrobial resistance monitoring program. And in that study, 25% metronidazole resistance and 13% clarithromycin. And another study, more recently, this is Journal of Clinical Microbiology, published from 2000 to 2008, 531 isolates in an Alaskan native population, 42% resistance to metronidazole and 30% to clarithromycin. So that's very interesting. Does that apply to a Southern California patient population? And again, that data is more than a decade old, so where are we at now? And no one is doing routine surveillance for this. CDC doesn't have funding and is not doing it. And like I said, clinical labs aren't doing this routinely, so we don't have even local laboratory susceptibility data. Some published risk factors for having resistance. There seems to be certainly regional and geographic variability, higher on the East Coast, which of course is good for us. But again, when you're looking at the global literature and a study published in Italy, does that apply to our Southern California patient population? Older age, certainly a risk factor for resistance, and that's probably because those patients are much more likely to have been exposed to clarithromycin in their life, because those are people who are getting it as Biaxin for URIs, for pneumonia, et cetera. Younger women have much more metronidazole resistance, and that's probably because it's very commonly used for gynecologic infections, including bacterial vaginosis. So older clarithromycin resistance, younger metronidazole resistance. Females higher than males, the gynecologic probably has something to do with that. And then ethnicity, Caucasians tend to have lower resistance problems than ethnic minorities. Most studies will tell you that resistance to clarithromycin can be as high as 20%. Interestingly, you can get in vitro cross-resistance after 1 exposure to macrolides. So just taking a Z-Pak, for example, is enough to in vitro lead to macrolide resistance. And certainly with clarithromycin, there are good data that you can have negative impact with pretreatment resistance, unlike with metronidazole. So this is probably the best study, and again, this is just true for clarithromycin, and this is one study, but with an OAC regimen, the pretreatment MIC was associated with poorer eradication rates the higher you went. Nice study in the 90s, this was published in Archives of Internal Medicine, metronidazole resistance 22 to 39%, clary 11 to 12, and again, more common in women, resistance increases up to age 70, and regional differences. So at least there's some consistency in what we're seeing with resistance. So I'm going back to the article I mentioned before, that nice review article, which I thought was very interesting, but this is the algorithm in their figure 1 for how to approach these patients. And I don't know how well you can see that in the back, but it's in your handout. So you start with H. pylori infected, and then it says history of antibiotic use. Well, anybody in this room never taken an antibiotic in their life? Yeah, exactly. So what does that actually mean? If I took a Z-Pak 15 years ago, am I likely to have clarithromycin resistance? If I took it a week ago, you might be concerned about it, but does the temporal distance from my last antibiotic use impact my resistance? Probably. Are there data on how to approach that? No. And then it says susceptibility testing, available or not available. Well, it's not available. So we can basically cross off this line here. And we can't do tailored treatment then because we don't have susceptibility data. And even if we did, it's hard to interpret and hard to know how to put into clinical practice. So let's assume that it's not available. And then we go treatment naive or at risk for resistance. And we just talked about that. So let's walk through a little bit of how we approach this. All right, so building our triple therapy as our backbone, what are some of the newer regimens? So the main ones that we'll talk about are quadruple therapy, sequential therapy, and salvage regimens. All right, so this is the slide I showed before. So this is the, again, first-line triple therapy. So a couple interesting points. First of all, the PPIs generally seem to be interchangeable, despite what the drug companies might tell us. There are really, in terms of H. pylori, not big differences in terms of outcomes. We know that you can get better outcomes if you dose the PPI twice a day and higher dose clarithromycin. We generally discourage using clarithromycin and metronidazole right off the bat as a first-line regimen, because if the patient fails, you don't have a lot of options available. Clarithromycin, for reasons that are not well understood, seems to be better than other macrolides, azithromycin and erythromycin, which is a shame because generally azithro is a lot more easy for patients to tolerate, especially elderly patients, than clarithromycin is. So quadruple therapy, this is the BMT regimen, so PPI, bismuth, metronidazole, and tetracycline. Generally appropriate as a first-line therapy. Higher pill burden, may be a little tougher, especially metronidazole. And certainly if standard triple therapy has failed, quadruple therapy is appropriate as a salvage. Dosing is challenging. Taking metronidazole is really rough, but some meta-analyses have been published showing that the efficacy and tolerability is generally about the same as triple therapy and quadruple therapy. This is available as Pylera. I'm sure a lot of you have used this, but this is bismuth, metronidazole, tetracycline, and then you add the PPI. It comes in a nice convenient pack, and you've got essentially, 14 pills a day. It's a high pill burden to take, but it makes it a little bit easy. What about sequential therapy? So there's pretty decent data that for patients with clarithromycin-resistant strains, this makes sense to use, and there's decent outcomes. So this is, instead of giving all the medications simultaneously for 10 to 14 days, you'll do 5 days of one regimen and then switch to 5 days of another regimen. And the classic sequential therapy is 5 days of pantoprazole amoxicillin, and then you drop the amoxicillin and switch to clarithromycin plus metronidazole. This was Annals of Internal Medicine, good outcome data, and I think for patients who've failed standard therapy, this is a very rational approach. The pill burden is pretty low. It's pretty easy to get patients to tolerate, so I'm a fan of this if it's necessary. The Sanford Guide actually recommends sequential therapy as first-line treatment. However, for us to recognize, most of the data on sequential therapy has come out of European and Asian populations. But there's very good meta-analyses and pooled analyses that essentially show it's comparable to triple therapy. We just don't have good data for American populations. Should it work for our patients? It should, but again, there's a lot of regional differences in how these patients respond. So I don't know if the jury's quite out completely with sequential therapy. So, recommended strategy. If you've treated the patient and they failed, this is their first failure. So you've done your standard triple therapy, you use clarithromycin, and they failed. So assuming that they were compliant, and again, that's the most important thing, then you have to assume now that resistance has developed to clarithromycin. Certainly, if they have any risk factors for resistance, that's another thing you're going to take into consideration. So first failure, using an alternative regimen for 14 days, preferably quadruple therapy if the patient can tolerate it. Ideally, you'd like to avoid antibiotics the patient has previously taken. Certainly trying to simplify the regimen if compliance is the issue is important. What if they failed multiple times? So again, now this is their third or fourth failure, and you're continuing to do your breath testing, and they're positive, and you can't figure out why you can't cure them. So again, compliance, most important. If it's available, getting a culture with susceptibility testing, not really available, so that's not a good option for us. Other options that you might want to consider are things like levofloxacin, amoxicillin, and a PPI, and there's decent data there at the bottom in that table, 87% cure rate. Moxifloxacin is another quinolone that's been used with good data. Rifabutin plus amoxicillin might be an option. If the patient's failing all of these, then you get into the science of voodoo therapy with this infection, which is basically, well, let's try this and hope that it works. And it's not very satisfying, but you're starting to come up with, well, let's try rifabutin plus levofloxacin and hope for the best. But I will say I really feel that for most of these patients, it's the compliance issue more than resistance or anything inherent to the problem. So other things that people have tried, amoxicillin, doxycycline, PPI, and bismuth, that's actually pretty simple and pretty easy to tolerate. Italian study, 92% cure rate. Again, might be a good option, a single study and out of Italy. Adding bismuth to triple therapy, that also seems pretty intuitive and pretty easy to do. And then lastly is the load, which is levofloxacin, omeprazole, nitazoxanide, and doxycycline. So lots of things out there, and unfortunately there is no best practice in this area where I can conclusively point to and say, if A, then B, but there are a lot of different options we might want to try, and a lot depends on how the patient's tolerating it and what you're previously used. So I'm not going to walk through this entire flow chart. This is in your syllabus, but I thought this presented a very nice, rational approach to how to approach this. But basically, if on your right, if the patient is not macrolide exposed and not penicillin allergic, starting either with quadruple therapy or standard triple therapy. If the patient persists infection, essentially using whatever you didn't use before. And then if they're allergic or prior macrolide exposure, probably starting with quadruple therapy makes sense. So I'll end there, and I'll be on the panel. We can do some questions later. So thank you very much.